This will be a little bit unusual presentation for me. Normally I like to show a lot of evidence, avoid opinion, and show a lot of x-rays, of which I'm going to do neither of those things. And this is going to be largely kind of what my feeling, my experience is about the challenges of introducing preoperative bone health optimization into your clinical practice. So the objectives are to identify the causes of failure, why we don't use bone health optimization on a regular basis, and some suggestions to overcome these obstacles. So some of the barriers that I have found myself, and we've also surveyed a number of other institutions and asked them why they're not doing it, is first of all, is lack of surgeon awareness that this is available and maybe should be done. We also have trouble of deciding which patients need it. We operate on a lot of people who are over the age of 50, for instance. Which ones of those do we really need to assess further and maybe optimize? How do we identify them? And what are the proven protocols for doing this? And also, many of us don't have anybody to refer to. If you send out for an endocrine consult for osteoporosis, most institutions it's 6 to 9 months. And then you have to deal with the insurers who deny medical treatment for osteoporosis. And then also you have a balance between what patients' desires for surgery are and their needs and urgency versus the optimization time it takes. So first of all, awareness. Scott went through why we need to be aware of this. Osteoporosis is common and associated with complications. Simply said, about 30 to 35% of patients over the age of 50 who are going to have spine surgery will have clinical osteoporosis. And the risk factors for complications somewhere are 2 to 5, odds ratios of 2 to 5 if you have. And what are the strategies for mitigation? Well, there are out there and they are published and there are guidelines for this, but most people aren't aware of them. And as Einstein said, we can't solve problems by using the same thinking we used when we created them. And this is a problem really on us. We have to step up and say, hey, I need to take hold of osteoporosis and make sure my patients are receiving the proper diagnosis and, if needed, the treatment. So let's answer who needs optimization. So we're going to go over indications for DEXA, interpretation of DEXA, and then talk about what is the definition of osteoporosis. We actually don't even agree on that. So this is a simple algorithm. This is a summary of most recommendations from some of the major societies for screening for osteoporosis in adults over the age of 50. And you could simply use this: females older than 65, males over than 70. I think even Dr. Savage can identify those factors in patients. If you've had a history of a fragility fracture after age 50, I hope orthopedic surgeons can take that history. And then the complicated one is to calculate a frax. How many have ever used frax in their practice? Okay, so that's a problem. Frax is a risk factor or a risk predictor of future fracture risk in 10 years. And it is now the current standard for how we decide who is going to be treated pharmaceutically. And you can do it with or without BMD. And the threshold here is if you do it without BMD, if you're greater than 8.4%, then you should go ahead and get a DEXA scan. Sensitivity of doing this is 100%. So in other words, if you answer one of these 4 questions, yes, get a DEXA, you will identify 100% of patients that you're going to operate on with the diagnosis of osteoporosis. Okay, how do you interpret DEXA? This is a problem. It's very confusing, these reports. But the thing you want to look at is the lowest T-score of the spine, femoral neck, and something called the total hip. It may be called the proximal femur. Or if the forearm was done, they call 1/3 radius. It's not the distal radius. They give you a distal radius. That's not what we're talking about. We're talking about 1/3 radius. And if you're ordering a test for a spine patient, see if they will do something called vertebral fracture assessment, which is looking for occult spine fractures. And then what is the definition of osteoporosis? Well, we all know the World Health Organization definition, which is a T-score less than -2.5. Well, what we're looking now, the more expanded, and we're going to call this clinical diagnosis of osteoporosis, which is now what's used to treat patients, is the C-score criteria, but also if they've had a hip or spine fracture, they're osteoporotic. If it was a fragility type fracture, so ground level fall, L1 compression fracture, they got osteoporosis. You don't need a DEXA scan. And if they're osteopenic and they have a radius fracture, they're osteoporotic. Or if they have this high frax risk, which you have to learn how to use. So what about protocols? Well, there are actually a lot of protocols written specifically for spine patients and orthopedic patients, as well as protocols written in AANS. There's also written similar protocols. And so these are available, and you just need to read these and apply these. They all end up suggesting that you risk stratify based on this diagnostic algorithm, based on DEXA and fracture history and fracture risk, and that will define your treatment. So here's the risk stratification. So it's three things. Low risk means you have a high T-score, greater than minus 2.5. You've never had a fracture, and the frac score with or without BMD is less than 20%. And if you're high risk, that means you have an osteoporotic T-score, but not too severe, and a MOF less than 30%, and you may have had a hip or spine fracture, but it's remote. And then the final one is severe, very high risk. These are very low T-scores, very high fracture risk, recent hip or spine fractures, or failure of medical treatment, multiple fractures. There's a long list of things that will get you that. And about 10% of patients will be in the very high risk category. So the low risk, you're not going to treat, just operate on. The high risk, the recommendation is anti-resorptive and proceed to surgery. However, if it's a high risk procedure, a 10-level fusion, maybe you want to step back and do an anabolic. And then the severe ones, these patients all qualify for anabolic therapy and really need a delay in surgery. What about the providers? I think this is the primary major hurdle. If you ask the PCPs to do this, it will fail. Almost no PCP will order an anabolic drug. So you're just wasting your time. You really need to get in the hands of a specialist, or better is develop the program within your own department. And many orthopedic departments have developed fracture liaison services that provide this kind of care, but even spine programs are now developing this. Or you coordinate care with a specialist, and a number of institutions like Cleveland Clinic and Mayo Clinic have endocrinologists that are working directly with the spine surgeons to facilitate this care, and it streamlines appointments. Another frustration is insurance denials. It's bad enough we get our surgeries denied, but we're ordering a medicine and then we get those denied. And what I recommend is the algorithm I just briefly touched on actually qualifies for current indications for those drugs. And so you're meeting the theoretical accepted criteria, and so you should be able to get these drugs approved. Of course, you're dealing with insurance companies who always make up their own rules, but we're trying to use the proper definitions. You have to know the language to use, and you need to be a little bit of a detective. You have to identify prior fractures, which will totally change the diagnosis. Look for things like height loss, use fracs and CT Hounsfield units, and you can then build a case that this patient has severe osteoporosis and therefore would qualify. We use a pharmacy department in our hospital who helps us with pre-authorizations. They're used to getting pre-authorizations for oncology and rheumatology, so they've been actually very helpful in taking a lot of work out. Now, the final one is patient urgencies, desires. Can we delay surgery? It depends on the requirements for bone health. What strength do we need? We're doing 10-level fusion with osteotomy. We've already had a patient who's failed 3 operations. Maybe we need more bone strength, as well as healing potential. And it's balanced against the severity of osteoporosis and against the patient's urgency. If the patient has neurologic deficit, it makes no sense to delay surgery to fix their bones. Is get them fixed, and you can always treat the bone disease post-op, because it's not going to interfere with healing. So if urgent, proceed post-op. So in conclusions, first of all, you have to educate yourself of why you need to do this and what are some of the options you can introduce into your practice. You should provide leadership for your group to make this happen, develop bone health programs, and take the time to provide bone health education to the patients about this optimization. A lot of our patients actually accept this more than they do even after they had fractures. They're pretty resistant to taking medications after fractures, amazingly, but they're actually quite willing to take them for this problem. Thank you.